Uh, is my screen being shared?
Yes, Rahul, yes.
Perfect, sir.
Yes,
So, good evening, everybody. I'm Dr. Rahul, and we will be discussing fetal risk assessment for trisomy 21 today evening. The topic is mainly around TIFA scan because during the nuclear scan, it is generally a software based. We will see it in the coming slides how to go about nuclear scan. So during TIFA scan, we take in consideration multiple soft markers and likelihood ratios. You will see subsequently that these two hover around only a two set of tabulated datas and their multiplication. So you see a simple equation of multiplication gives us a very good insight about the risk assessment. This can be done by easily by a fifth, sixth standard student, and so can be easily done by our less educated staff as well. And you will see that it is so simple that only in 30% of the cases only you will need to reconfirm this thing, their calculations. So starting with the risk assessment benefits, this risk assessment benefits this risk assessment helps us quantify the risk of a mother. This quantification helps us in stratifying the risk into different high, intermediate, and low category. This helps us to form a protocol how to go about individual cases and helps us to get a desired outcome. This desired outcome means whether the Down syndrome is present or not present. This helps us in communicating and convincing the patient to go for higher tests, which may be costly to his or her pocket. And once they are convinced, then we set a rapport with the family. This rapport helps us to overcome any potential medical legal problems. So this risk assessment is very necessary in TIFA scan. So what is the present status of our reporting? The present status of reporting is we all, including myself, used to report that there is a single live intrauterine fetus or twin live intrauterine fetus without any congenital anomalies, or maybe we also write that without any presence of soft markers. This implies that everything is good with the fetus. But is it so? Is it 100% correct? No, it is not. We all know that. So this difference of reality and expectation creates acceptance problem in case something goes wrong. And a good rapport with the patient, a good communication with the family will help us that it does not take a medical legal route. So we want to upgrade from that reporting to addition of these three lines in the report: the risk before the scan, which may be combined risk or age risk, evaluation of soft markers, likelihood ratios, and then finding out risk after the scan, categorizing it into high, low, and intermediate category, and then advising it what needs to be done in written and verbal way so that the message is very clear to the patient, and it is also there in writing for the gynecologist. So if we see the age risk for Down syndrome, it is given in this table. I will be giving printable copy of this table on the WhatsApp later, so we can have it for a ready reference. So if we see this age risk at the 20 years, the risk of a mother having a fetus having Down syndrome is 1 in 2000, which goes to as high as 1 in 100 at the age of 40 years. 49, it is at the age of 49, it is 1 in 10. So if it is there with us, then we can refer to it and can calculate in case the lady is coming to us during the TIFA scan for the first time. So this becomes the risk before the scan. The next we come down to combined risk. Combined risk, as we know, takes in consideration the nuchal scan findings and biochemical markers of beta-HCG and PAP-A. generally what we all follow is that we do a nuchal scan, then that report along with the blood sample of the patient goes to the lab, and the lab gives us combined risk. But when we give the nuchal scan report, in that also we can mention the risk which is there for the baby to have Down syndrome. That risk is actually software based. This software can be freely acquired from the fetal medicine site if we register and take that certification of theirs. However, they have also provided a free online risk assessment thing. This link is here. When we click on this link, we go to this site. We go to this site, and on this site, we can see fetal risk assessment is getting open. So we put the examination date. We put the examination date of 23rd today. Then because we don't have sir,
राहुल थोड़ा वॉल्यूम कम है.
ठीक है सर, मैं थोड़ा पास आके और बोलता हूँ जोर से.
हाँ थोड़ा सा. यस थैंक यू.
तो for this site we go to the date of today's scan, and then we put the date today. Now that we are doing a nuchal scan, we don't have biochemical markers. We select no for PAPE, no for beta STG. We put the date of birth, random date of birth for some, we can put the date of birth of some 20 years, 25 years behind. So we can keep it 88. We selected the date of birth of the patient. Previous baby, not Down syndrome, not 18, not 13. And then fetal crown lump length. Actually, are you people able to see my slide? The internet slide.
Yes, Rahul, we can see the slide, but there is some graphics over it.
Okay.
Please remove that graphic.
Okay.
These lines are random lines. There are some random lines on the slides.
Okay, I just see. You are trying to say, I think random lines are gone. And you see this thing. Share. Are you able to see this slide? Yes, you are able to see. And so this is the site. When we go on the, okay. So can we see this online site of fetalmedicine.org? Perfect. So on this site we go, we put the examination date, we put we select no for PAPE and beta CG because this is before the biochemical marker has been sample has been sent. We put date of birth of the patient. We select no if there has been no history, no bad obstetric history, and then we select the fetal crown lump length. For example, we select 55. Nuclear translucency we select 1, and then we select heart rate as 150, 159. So, and we just click on the calculate risk. So now we can see that the risk from history plus NT plus FHR is coming out to be 1 in 5,000 for 21, 1 in
इंटर करियो मदर के एज इंटर करियो.
I think somebody's audio is interfering with things. Trisomy 18 is 1 in 3333. Trisomy 13 is 1 in 1 lakh, 1 in 10,000. So this is nuchal scan risk assessment without biochemical marker. We can keep this site handy, and we can calculate this in every patient and give it in writing. So now coming back to my slide again. Going back to this PowerPoint slides again. Now the PowerPoint slide, we are back to the presentation. So this is how nickel scan risk is calculated. Very easy, nothing to be done, just online site help. Now I will digress a little bit for one common situation which we all face. This situation is that patient often asks after nuclear scan, ki Doctor Sahab, is double marker very important to be done because it costs around 2,500, a little pricey thing. So my advice is that we must very sincerely say yes to it, and we should also write it in early obs scan that double marker and nuclear scan to be done between 11 to 14 weeks, because it is very important scan. As you can see, that detection rate is 90 to 94%. If you see the efficacy of different tests, this thing reinforces the importance of this test to the patient and also shifts blame away from the radiologist and also the gynecologist. If gynecologist will be safe, so he or she will definitely try to keep us also safe. So now that age risk and combined risk we have calculated, so we can stratify it into high, intermediate, and low risk. Intermediate risk is 1 in 250 to 1 in 1000. High risk is above it, and low risk is below it. We all know this. So when the risk is high, we straight away go for invasive test, which includes CVS or amniocentesis. If the risk is low, we go for a normal quadruple marker and TIFA scan. However, if the risk is intermediate, then we need to go for early TIFA scan at 16 weeks, quadruple marker at 17 weeks, and depending upon their results, we can go for NIPT or invasive tests. A word about NIPT is that it is done specifically for Down syndrome screening. It is not a confirmatory tool. It is again a screening tool and done only for Down syndrome. It is gives a very high false positivity for Edward and Patau syndrome. So it is not done to detect them. So this is the basic protocol, and we will further see how our risk categorization goes along with it. So Agathocleos and his team did meta-analysis of second trimester markers for trisomy 21 and gave us likelihood ratios of each and every marker. They included 48 studies from 1995 to 2012, and these are the 9 soft markers. We all know this. So how we will calculate the risk of TIFA through this? The individual likelihood ratio, with the help of individual likelihood ratio, we calculate the combined likelihood ratio of the study, and we divide the risk before the scan, that is either age risk or combined risk, by this combined likelihood ratio, and we get the risk after the scan. We will very soon see all the calculations, so it will be very clear. There's a small caveat in the sense that if we see all these markers, their existence is independent of each other. Like when absent nasal bone is present, then URSA may or may not be present. When ventriculomegaly is present, then the thicker nuchal fold may or may not be present. So they are not at all correlated. However, if we see the last 2 points, short humerus and short femur, they are very highly correlated. When short femur is there, then there are very high chances that short humerus will also be there. When short humerus is there, then very high chances that femur is there. So we we take out of this 9 thing, we take out either short humerus or short femur. And if we calculate the differences, it is not very much. You see the calculation difference is from 0.13 to 0.12, which is not at all very high. So let's see how we go ahead with the calculations. The complete crux of the article is in this table. This table seems a bit cluttered, so we will take out the relevant data from it in a simpler table, and we found this table. So this table has positive likelihood ratio of each and every marker and a negative likelihood ratio of each and every marker. So this table is actually what is required for us. The equation through which we will go ahead is given at the last. The total LR of a study can be calculated by multiplying positive likelihood ratio of the markers which are present with product of total negative likelihood ratio of all the absent markers except humerus. That is why I have highlighted the humerus separately, that we will not include the negative likelihood ratio of humerus in the product of all negative likelihood ratios. The complete thing comes out, the complete further processing of this thing in a different ways will be from this equation only. We will see how this we can take shortcuts, how we can make shortcuts from it. So what are the possible three scenarios? The possible three scenarios, which the commonest of them is that all soft markers are absent. This is approximately 60 to 70% of the cases. So if we have a shortcut for this, we can very quickly evaluate the risk. The second commonest is only one soft marker being present. And the last is combination of soft markers being present, but they are hardly 5 to 10% in which combination of soft markers are present. So let's see how we can get to the shortcuts. So in case no soft marker is present, the equation is very simple. We multiply all the negative likelihood ratios of all the markers except short humerus, which gives us the result of 0.13. This 0.13 can be remembered, and the risk before the scan is divided by this 0.13 to get a new risk. For example, if the combined risk or the age risk before the scan was 1 in 3002, so after the TIFA, the scan becomes 3002 divided by 0.13, that is 23092. It goes from low to very low risk. This simple thing will help us to calculate the risk in 60 to 70% of the cases, but just remembering 0.13 when all the soft markers are absent. We will do some examples so it will make things a bit easy. The second commonest example is when the solitary soft marker is present. To calculate the solitary soft marker likelihood ratio, we multiply the positive likelihood ratio of the soft marker which is present to negative likelihood ratios of all the soft markers except short humerus. We name it isolated likelihood ratio, and we can calculate this for every soft marker and keep it handy for quick evaluation. Like this example, if suppose in some fetus URSA is present, then its positive likelihood ratio is 21.48. We multiply it with negative likelihood ratio of all rest SMs except humerus, that is these 7 soft markers, and we get the value of 0.18. So multiplying the positive likelihood ratio 21.48 to the product of all negative likelihood ratio, that is 0.18, gives us the factor of 3.9. Now we divide the combined risk of 3002 by this 3.9, which gives us 770. So the risk after scan is 1:770. The low risk has been converted into intermediate risk in the TIFA scan. So in the category of intermediate risk, we need to go for amniocentesis like invasive test. So this is the table in which I have tabulated the isolated LRs of each and every soft marker. If we see a bit carefully, the last 4 soft markers, their isolated LRs are very close to 1. So if we divide anything by 1, the answer is same. That means if in a fetus, a solitary soft marker consisting of pilotesis, either echogenic intracardiac focus or short humerus or short femur are present, then their risk does not change. We will get it a bit more insight into it when we will do some examples. But my point is, in case there is a low risk before the TIFA scan, the presence of solitary soft marker among last four does not change the risk and does not uh, deserve an invasive test like amniocentesis. Incorporating this into the table, incorporating this into the table, we get this complete table, which is the crux of my presentation and Agatha Cleo's complete hard work. So we have this one table which gives us positive LR, negative LR, isolated LR, and combined LR along with this equation. I will be giving this table in a printable format along with the age risk for Down syndrome on the WhatsApp group, so we can have a printable copy for a ready reference. Now coming out to the examples so that we can be more comfortable with the equation, I will just like to go to the Excel sheet in which I have done. Just a minute. I'm going on to the Excel sheet. Can you see the Excel sheet? Yes, you can. So perfect. Now, in this Excel sheet, we have on the left side all the soft markers, positive LR, negative LR, isolated MR, isolated LR. We have combined negative LR of 0.13 as we have all calculated. And we have these case examples. And here we have, just for revision, the high, intermediate, and risk category. So all those who are not very well aware of Excel sheet, I just give a small demo that if in any box we put an equal to sign, it becomes like a calculator. We can simply put digits, multiply, and enter, we get the answer. So every box we put equal to sign becomes a calculator like thing. So we'll take help of this Excel sheet and calculate the risk for TIFA scan. So suppose the case one, the lady comes straight away for a TIFA scan, no previous scan done, no nuclear marker, no biochemical marker, no quadruple marker, straight first scan is the TIFA scan. So the risk before the scan is this age risk, which is 1 in 200. If we see, this is a high risk category. So we do a TIFA scan and we found that there is no soft marker present. So what we do, we simply divide this risk by combined negative LR and get 1538. So this 1538 becomes low risk and we need not do anything. In case 2, the age risk was 100. That means the mother must be around 40 years of age. The combined risk comes out to be 3002 approximately. The quadruple marker was not done because the risk was low. But when we did TIFA scan, we found that there is an absent nasal bone which was not detected during a nuchal scan. So this is a single soft marker present. So for a single soft marker, we straight away go for the isolated LR. We have already calculated it. It is 6.58. So we simply put an equal to mark. We before the scan risk is this. We divide this with isolated LR of this thing, and the answer comes out to be 456.2. So this is intermediate risk. Intermediate risk during the time of TIFA scan, we need to go for invasive test like amniocentesis. We come down to the case number 3. The age risk is around 1500. The combined risk is approximately 20,000. The quadruple risk or integrated risk is approximately 25,000. However, there were two soft markers present, URSA and ventriculomegaly. So we first calculate the likelihood ratio of this study. So we go for positive LR of these two markers. We go for positive marker URSA, then we go for ventriculomegaly, then we go for negative LRs of rest all markers except short humerus. So this gives us a total LR of the study. Now we divide this risk by this LR, total LR. The risk comes out to be 217, which is very high risk. So we can straight away go for invasive tests. Case 4, if we see, case 4, the age risk is 1200, the combined risk was 240, the quadruple or integrated risk comes out to be 2000. There was pylectasis present and echogenic intracardiac focus is present. So we calculate the total LR of this study. So pylectasis positive likelihood ratio is this. Echogenic intracardiac focus is this. So we have taken the positive LRs of these two present markers, and now we will multiply with the rest all negative markers. It can be done very easily on the calculator as well. Just for the demo, I have taken this Excel sheet. This is what needs to be done by us. Sorry, I'm taking this. So we get the total likelihood ratio of 7.9 approximately for this study. Now dividing this 2000 with dividing this 2000 by 7.9, we get 254. Again, a high risk, very near to high risk. So we need to do invasive test. So if we see these four cases, there was a high risk in first case, which was converted into low risk. There was a low risk in the second case, which was converted into intermediate risk. There was a very low risk in case 3, which was converted into very high risk. And same in case 4, which was quite a low risk, but it was converted into a high risk. And so knowledge of this, we can clearly, protocol based guidelines are there. We can convince the patient, and at least we can give in writing, it's patient responsibility, gynecologist responsibility, whether the person is going for further tests or not. But we are out of the medical legal problem. Now, the thing which I was previously discussing, like case 5, the age risk is 1050, the combined risk is 8000, and now one of the soft markers is present, which has LR of close to 1, isolated LR of close to 1. So either echogenic intracardiac focus or pylectasis or short humerus or short femur. So if we see 8000 is the risk before the scan, if we calculate this risk, the TIFA risk of this scan, like 1.08 for pylectasis, isolated LR of pylectasis, then the risk reduces furthermore. The presence of echogenic intracardiac focus or pylectasis does not significantly change the risks. So invasive tests are not required for them. However, it is being done in our society, that's a different thing, but we can skip that thing. It is actually individual's choice. So coming back to the presentation. So this is the table. If we have printout of this thing, we can very easily calculate all the likelihood ratios as I have told you. But we do whatever we can to make our life safe and sound, The God will send few idiots which will make our life interesting. Like this person in this message. We can go through this for some fun. I'm sorry, I cannot explain what WTF means on this forum, but I think most of you will understand that. And I complete my presentation over here. So thank you all for patient listening and allowing me to enrich your professional lives. I will not embrace Dr. Tanuj Garg by saying thank you to him for giving me this opportunity. Thanks to all teachers, colleagues, and patients to make me this competent. Thank you, Almighty. May He keep us healthy, happy, and contented always.
Nice presentation, Rahul.
Sir.
But it needs time to understand these all calculations. But this is definitely very good. I read somewhere in the likelihood ratio, but how to calculate all the things are very clear by this. I definitely need the video of this presentation. Hope you are recording it.
Yes, sir.
So if I miss something, or the many people must have missed it, because this is all purely a Excel sheet and calculation. So these people should know. Hopefully you will send the recording.
Yes, sir, absolutely.
And now the things are over. Is there any questions? Renu, I should say you should take charge for the questions only.
Yes, sir. Good evening, everyone. Thank you, Dr. Rahul, for the wonderful presentation. You have really made the topic very interesting and easier. We are grateful for the time and effort you took to share the latest updates with us. Your enthusiasm and energy are really admirable. We hope and wish to see you soon again with a new topic. Secondly, I would like to thank the entire audience for their patient listening. Also, I would like to thank the technical staff for their support. And last but not the least, I would like to thank Dr. Tanuj sir for his sincere and selfless efforts to make this group an advanced learning platform. Thank you all. Good night.
Thank you, Dr. Renu, Dr. Tomar sir, Dr. Rahul Rai, and the audience. But definitely we need to practice this thing. It's not that easy. So we need a video, definitely. Rahul, hope to share. Right. Thank you very much. Thank you very much.
Thank
Yes,
you, Tomar sir. Thank you, Renu ma'am. Thank you, sir.
Let's finish. Let's close the topic. Let's close the meeting. Thank you very much.
Thank you. Thank you. Very nice. Very nice.
Thank you. Thank you, everyone.
Hello, Rahul sir. Hello. Are you there?
Yes, I'm there. Please.
Yes, I'm Dr. Deepak.
Hi.
This was a very nice presentation, sir.
Thank you. Thank you, sir.
I have one question, sir.
Please, please.
This was regarding the intermediate risk.
Yes.
So, is there a this thing like we have to do invasive testing in every case of intermediate risk?
No, actually, intermediate risk at what level? At the level of nuchal scan, combined risk, or at the level of TIFA risk? At the level of TIFA scan.
Okay. So we have to divide in between.
See, if the TIFA scan intermediate risk is coming, then we don't have any option left. We have to decide very categorically whether the baby is going to be normal or not. The risk is intermediate, definitely 1 in 250, or between 1 in 250 to 1 in 1000. But it is not very high. So it is the call of the patient, how convenient the patient is with the tests. We have to decide, we have to give very categorically that we need for invasive, because tomorrow something happens, the blame will come on us.
Okay.
But if the combined risk, the intermediate risk is after after the combined risk, then we have other options like TIFA, early TIFA scan, quadruple marker, or NIPT. So we
Right.
can subsequently change the risk afterwards.
And how come NIPT is, although the sensitivity is very high of NIPT, so
Only
can
for
we
Down
replace
syndrome. Only for Down syndrome.
only for Down syndrome, right?
Yes, it
So
can. It
we,
can. It can definitely change the risk. It can definitely change the risk. But
no, can we replace the combined screening or the quadruple marker with NIPT?
you know the cost difference.
Yeah, I know.
So 2,500 rupees and 25,000 rupees. This
No,
is such a.
NIPT is in today's scenario it must be around 15,000, I
But
guess.
still, sir, in given Indian scenario,
Right.
2,500, and people are not going for 2,500 rupees test because it is
No,
costly to
I
their
I I
pockets.
I am talking in terms of the results of the test and the
Sir,
sensitivity of the specification.
it is again a screening tool.
No,
In case
both
it,
are the screening tools. The
uh,
quadruple and combined markers are the screening tools.
yes. So going for such a high costly test on the first go, I don't think it is justified. But when the things come on the individual level, he or she may choose for himself. But for the
Right.
first time, we should not advise. We should avoid advising it,
Okay. Okay.
sir.
And in the A priorities, we should take age only the risk factor, or with age sometimes I've seen the cases people are taking BP also, the resting BP and
Sir, presently, what is available to us in the soft marker, whatever software is available to us latest, we can go according to that. BP and this thing can be taken for preeclampsia risk, but for
right.
the Down syndrome risk, I don't think it is there. I need to update it. I need to update about this thing.
Yeah. Thank you so much, sir.
Sir, welcome,
Yeah.
sir.
Yeah.
This mean arterial pressure is taken for pre-eclampsia screening only.
Yeah.
Yes.
Not for me. Preeclampsia. Thank you, sir. Good night.
Good night, sir.
Very nice presentation. Thank you very much.
Thank you, ma'am.